So stent dislodgement during PCI is a rare complication, but it is a serious complication. So angulated, calcified, and previous stented vessels are predisposing. Actually, there was yesterday one presentation, similar case, and that ended in surgery. And today morning also there was a case which the similar thing happened, and that also ended in surgery. And most of the time it is a lesion-related factor, but sometimes stent-related factors can also be a factor. And this lead to myocardial infarction, need for surgery, death, bleeding and vascular complication, and if it distorts the periphery, it can produce stroke and distal embolization. And immediate and appropriate management is needed to prevent morbidity and mortality. And management depends on whether the stent loss is partial or complete loss with the guide wire in situ, or total stent loss without guide wire and loss into the peripheral circulation. And different options are available. That is small balloon technique, multi-wire technique, and retrieval using forceps or snares, and deploying it into the site where it is dislodged or crushing to the wall of the balloon and the stent. So our patient is a 75-year-old male. He had a CABG in 2004 and LIMA2 LAD and SPG2, LIMA2 D1 and SPG2 LAD. We don't know why. And he had an acute coronary syndrome in May 2022. ECG showed STT changes and troponin was elevated. And he had undergone an angio there and native vessel triple vessel disease. And with patent LIMA2 diagonal and tight stenosis of the SVG graft to LAD. And the patient was referred to us for saphenous vein graft angioplasty. And this was the lesions. He had a proximal tight stenosis of the RCA, LAD, mid LAD total occlusion, and multiple tight stenosis in the PDA. And instead of graft angioplasty, we thought of attempting CTO to the LAD because it is a 8-year-old graft, and distally there was some stenosis, and before this one also there was some stenosis. So we attempted by femoral approach, and with we tried to cause the lesion, and it was difficult, but finally we could succeed in doing angioplasty to the LAD, and we put 2 stents and 48 mm stent in the mid to distal LAD and the left main to LAD stent, and finally we got a good result in LAD, and next we did PTCA to the PDA also, and that was also very good result. And after a few months we attempted PCA to the LCX and OM and radial approach, and we used 7F EBU guiding catheter, and check angio showed patent stents in the left main LAD and the PDA. And LCX was wired and LAD was also wired. Pre-dilatation was done to the obtuse marginal branch and ostial LCX. And serial dilatation with NC balloon, and we went up to 3 mm NC balloon with the dilatation of the proximal LCX and the ostium. And attempt to stent using an Science Alpine 3.5 into 23 mm stent. And it was difficult to push the stent, so we thought of retrieving it, but stent got entrapped in the left main stent to the LCX. And when we tried to retrieve it, there was some crimpling, and so the balloon and the wire also came out. Yeah. So this was the initial wiring, and we can see that angulation. It was almost a 90-degree angulation, and we wired LAD and the LCX, and we did balloon dilatation to the OM, and serial balloon dilatation to the proximal LCX and the ostium of the LAD, ostium of the LCX, and finally this was what happened. So there was a stent which is almost 90-degree and into the LCX and in the left main, and there was a strut. Probably the stent must have got stuck in the strut, and yes, this was the, and actually we missed that shot, capture that image, but finally this was the stent. Yeah, deploying the stent, trying to deploy the stent. It was not able to push the stent, so we thought of taking it through a guideliner. So while we tried to remove the stent, this balloon and the wire came out. So this was, we can see that that there was some crimpling, and that got stuck in this one, left main. So this is an algorithm which is recommended by the EuroPCR, that is, if there is a total stent loss with guide wire loss, and try to retrieve it using either a snare or a biotome or a forceps. And if retrieval is not successful, if failed, then crush the stent, but it is a last option in case of left main. So in this case, retrieval was almost impossible because we know there was a stent and this was stuck in the ostium of the left main stent, and there was some crumbling already happened to the stent. So we initially secured a safe this one, wired the LCX through the side of the stent, then tried to pass small balloon, and then crush the stent initially at the ostium. Then again tried to pass bigger balloons. Initially it was difficult, but with difficulty we could pass bigger balloons and crush the stent in the ostium, and again after that in the left main. So after that we took a balloon, and a balloon assisted guide liner we introduced into the LCX, and that showed that the OM lesion was okay, we can leave it on 10 leg reset, so we left it. And we took another stent. This time it was a synergy stent. Initially it was a Science Alpine. And then positioned the stent at the ostium of the left main. We are very careful. We have to be very careful that we should not miss the ostium in this case, because there was a hanging stent in the ostium of the left main. And finally we deployed the stent in the left main to LCX, and then flared the ostium of the stent. And initially we got a result, but we can see that there was some pinching of the LAD ostium. And then we did a port to the left main, then did balloon dilatation to the ostium of the LAD, then a final kissing to the LAD and LCX, and a final port to the left main. And this was the final angiogram. We could see that there was a good flow in the LAD, LCX, and so this we finished at this. Then the patient had an uneventful post-procedure period. His pain subsided and he was hemodynamically stable. He was discharged on the second day, and he had 2 episodes of syncope. So we are evaluated by ECG, troponin, echo, and other thing. Everything was normal, but because he had some atypical angina and 2 episodes of syncope, we were worried what will be, is there anything related to the left main? So we did a check angiogram after 1 year, 3 months back, and this was the angiogram done 3 months back. So the stent is patent, the left main to LCX stent, and the left main to LAD stent is patent, and the LAD stent is patent, and also the RC is patent. So he's doing well. So stent entrapment is a rare but potentially fatal complication, but now the incidence is decreasing because of the improvement in the techniques we have calcium modification techniques, we have intravascular imaging. So this complication is likely to be less in the future. And just 1 minute, you can show that slide. Yes. 1 slide only.
Can you give him one more minute, please?
So
just give him the slides.
In 2007, the incidence was about 0.29% among 4,797, and most of the cases ended in coronary artery bypass surgery. And 1991 to 2012 meta-analysis, the incidence was 1.3% among 77,665 PCIs, and 19% ended in CABG, 80% had MI, 19% death mortality, 3% vascular complication, and 0.9% stroke. And Bilakis et al., they reported their data from 1994 to 2004. This was 0.32%. With 86% they could retrieve it, and 40% they had to crush it. And in 2016 meta-analysis, the incidence was 0.56% among 25,996 PCI, and no death, no CABG, and all this were managed percutaneously. And this is the algorithm which is suggested by the EuroPCR in partial stent loss. So if the balloon is inside, inflate it to a small 3 mm atmosphere and try to retrieve it. And if retrieval is successful, that's okay. If it is failed, pass the inflate 3 mm balloon and try to push it, and then see whether the vessel size match or mismatch. If the vessel size is matching, maybe we can deploy it and can use another stent in the area where we are supposed to put the stent. And if there is a stent size mismatch, then use retrieval technique and either snare it or use biotom or forceps to remove it. And if it is failed, then the last option will be to crush the stent, and this will be a last option in case of left main stent. So take-home message is calcified lesion, extreme angulation, inadequate predilatation, and hindrance due to previous stent. We should anticipate this complication. So crushing the stent against the wall by another stent is an option in emergency situation. So the prevention will be by adequate lesion preparation, use of intravascular imaging, and guide extension catheter. This can help to prevent this complication. And in